Thank you very much. Good evening to you, ladies and gentlemen. And I would like to thank President and the Council for inviting me to share my thoughts on this topic. And my topic for today is three sides of the coin. So without explaining that to you, I would like to take you through sides. First, the first side of the coin, a case scenario. This was a 16-year-old girl, like today. It's just 1 month before level examination. That's why this case came into my mind. And came home and did not come out of the room. And parents noted she behaved abnormally because she didn't want to come out. And when she was asked to come out, she came out with a bed sheet covering her face and a pillow as well. So they thought something may have happened at school, and when they checked, yes, she was a good so-called bright student, and a teacher has asked a question and she has given a totally irrelevant answer, and the students have laughed at her. So they thought, okay, she's going through stress, so we'll give a little bit of time. And they waited for a day or two, nothing doing. She's talking irrelevant things, and then they thought of doing traditional treatment. And then still, maybe because of stigma, or maybe they didn't want to, call their only daughter a patient who is having a psychiatric illness, so they took her to a physician. And physician also listened to the story, sudden onset, there's some incident, unpleasant one in the school, coming home and behaving abnormally, and the age is also 16 years. So then he asked to send her to a psychiatrist. The psychiatrist examined the patient, and because of she was disoriented and referred back, and few days later the diagnosis was revealed, that was meningoencephalitis. So there the treatment got delayed, and there were little issues with the outcomes were not very good. So this is a typical patient who has presented with psychiatric symptoms, but actually the diagnosis was a medical problem. And this is a very common scenario we see day-to-day life, and also because of the other things, it gives such a flavor. My God, this is psychiatric. Everybody, even when a patient gets admitted to a hospital, even the attendants, the nurses, and everybody says, oh. And if they bring a diagnosis card, that makes it worse, because they think always diagnostic, if there's a diagnosis card where the psychiatric illness was written, it should be always psychiatric. And then can you spot this leaf-tailed gecko? Can you? Right? It's there. And this task is also difficult like that, because everybody knows that's a tree, right? It's a tree, everybody knows. But it's very difficult to spot it. Now, you're not a bad doctor, because you have experience more. With more experience, your critical thinking is very fast. I have seen patients, this is this, right? But what I am requesting you today is think about how to spot the gecko in the tree. So these underlying medical conditions presenting as a psychiatric disorder can be challenging for physicians. And when they come to us, it's psychiatrist, it's again challenging for us to say this is not a psychiatric illness. So we both have to work together. So few points may be important to consider are, if the patient has normal functioning prior to the onset, this is something you have to think about. This girl, she was fine up to that particular day. And also the unusual age of onset. But this girl, usually, after 16, and with stressors, O-level and all those things, it's common. It's not uncommon. But this is something you have to think of. An absence of past history or a family history of a psychiatric illness. And also history suggestive of substance use or prescribed medication change or adding new medication. So usually I ask my colleagues to check the poison chart, the drug chart, whether are we giving something to make them ill. And over-the-counter medications. They are very popular in Sri Lanka. And also the fluctuating mental state, fluctuating levels of consciousness. And we think this is this illness, and when we are treating, if it is not getting any better, the treatment resistance is also a place where we have to suspect this kind of an illness. And the patients with a past psychiatric history, we have to be extremely careful because sometimes their initial presentation is different from the current presentation. Recently also there was a patient who had panic attacks presented with a different bipolar-like or manic-like features. So then we diagnose it as an organic brain disorder. So the quality of the quality of the presentation is different from what he had before. So if we can just think about these things, it will give some clues to identify the culprit behind. So that is the first side where the psychiatric presentations can mimic the medical illness. Then we'll move to the second side. My second case. This lady was 37 years, single mother with a 7-year-old child, and she had a family history of ischemic heart disease, and according to her, brother died at young age due to a myocardial infarction. But actually it was a sudden death, right? And this lady presented with episodic chest tightness, palpitations, and difficulty in breathing. And she has gone to many doctors, and many investigations were done, and already on treatment for ischemic heart disease and bronchial asthma. And later on, after passing almost all the physicians and subspecialists, and when she came, we diagnosed her having generalized anxiety disorder, and these episodic things were panic attacks. So she was treated, and she gave her permission to tell her story afterwards also. Now she's again back with her husband, living quite normal life. And earlier she thought her brother died of myocardial infarction, and that was a sudden death due to some other reason. Because when the patients tell us stories, sometimes we tend to, we have to believe them, but that is their own interpretation. And so this time it's the psychiatric illness which present like a medical illness, of course, with a strong family history, and this type of presentation, anybody should include this ischemic heart disease, and those things should be considered. But the hidden thing, how are we going to identify? Now these animals, you may have seen this picture before. Some might say this is a flatfish, a lionfish, a sea snake, and jellyfish, and all that. Actually, all this is one mimic octopus. So in psychiatry, depression and anxiety disorders, they are like this mimic octopus. They can take any shape, especially in our part of the world, the Asian communities. They present with a lot of somatic symptoms, the burning sensations, and sometimes we miss them because we learn the ICD-10 or DSM-5 criteria, and currently we are adding these things also because of the culture. maybe where our expression is different from the original symptoms. And Peradeniya Depression Scale has now included all these symptoms to diagnose depression, especially in Asian communities. So these presentations can go anywhere because we don't have a referral system or something like that similar to the UK. Patients usually diagnose themselves, and with the freely available private sector, they might, if they think this is a respiratory illness, they might go and channel a respiratory physician. So usually in Sinhala දේශේ අපි මහත්තයෙක් වැළුවා මහත්තයාට ලෙඩේ අල්ලගන්න බැරි වුණා කියලා. So they will go to the next nona or the next මහත්තයා according to what they think the illness is. And usually from doctor to doctor and from the the patients who are sitting with them also, they relate the stories, and it's like a snowball. Little by little, it takes its own shape and ultimately come to you, the internal specialist in internal medicine, because after passing everybody, this is the one before last. Last is psychiatrist, one before last is the specialist in internal medicine. So at times it's so weird and so bizarre that they have so many multiple somatic complaints. Some iatrogenic by neighbor, iatrogenic by the next patient or the physician, and various myths and beliefs and all. So therefore we have to be careful when they present. Always try to find out these two questions. I mean, you came to me because of, is this because of the severity of the illness or the pain or whatever the symptom they are having, or do you have any underlying anxiety or fear or something about the symptoms? That is some valuable thing which you have to ask. And also see whether can all these symptoms be explained by a known medical problem. Usually there are some unusual, unfitting things, like there's an animal who barks, wags his tail but with two horns. Like, there's something abnormal. It's something not quite right. And with that, this is the psychiatric illness presenting as a medical problem. And the third one, the last one, this case is about a lady, a 24-year-old married lady, who was diagnosed patient with SLE and on immunosuppressive therapy as well as oral steroids. And she came for regular clinic follow-ups. But one day, her husband came and told the doctor, today, doctor, my wife refused to come. She's very stubborn nowadays, so I just came to collect the medicine. So the doctor said, stubborn is good. They'll become impossible. It's a common problem, mate. Reassured the person and gave the medicine and sent the husband home. And then the patient came back to the hospital, but in the emergency treatment unit after a road traffic accident. She had an argument with the husband and told he is jealous about her abilities and talents. And then he drove his car without license, or she has never driven a car, and met with this accident. So for SLE, she was on these drugs, and also we know that SLE can present with neuropsychiatric manifestation. So this is the third side of the coin, which I thought, like, we know a caterpillar will end up like a butterfly, and there are in between stages. But at times we forget, if we see any other place, my God, caterpillar, we don't get the nice feeling of a butterfly, right? Or the other picture, where it's always there, but at times we tend to focus on one thing. So this is the main two surfaces, and this is the third surface. So if we can educate the patients about, especially when we diagnose illnesses like SLE, multiple sclerosis, Parkinsonism, or any other tertiary syphilis, HIV, it's any illness with neuropsychiatric manifestations, that the early signs and symptoms of that they can present like this, they will let you know, and we also should know, and we will take these complaints seriously. So that is the third side which I want to tell you today. So why are we focusing on these three sides? Because we might give harmful treatment, and we might delay the treatment, and also for cost for the health services and the family is enormous, because sometimes they undergo same investigation again and again, and also the consequences, disability and death, they are serious. So these are few questions worth asking when you diagnose a patient who is having a difficult, atypical, or a tricky presentation. So are these presentation or the symptoms typical of this disease? Is there anything atypical here? Or are these symptoms better explained by a primary medical disorder or a primary psychiatric disorder? And also, can this be a direct consequence of a primary medical disorder? And also, is there a temporal relationship with stress, substance use, or any medical symptom like fever and headache? So it's very important to ask from the patient again and again what happened first. And then, because they are also in a panicky situation, they want to tell us what is important for them. So we have to listen to that and then ask, could you please repeat, what was there initially, fever or the psychiatric presentation or abnormal behavior or the problem? So like that is a very good way of analyzing these problems. So these questions will give you a clue to the diagnosis. And all we need, because I have done many mistakes in my life, and we learn from our mistakes and from other people's mistakes, and we want to give better care to the society. So all we need is an open mind, and we have to be critical in our thinking, because with experience we know sometimes this is this, but at the same time, okay, if this is not this particular illness, what else can this be? And also the willingness to re-examine the diagnosis. And if the presentation changes or unexpected symptoms appear, to go back, rethink and reanalyze. And this should be done both we psychiatrists and you medical specialties, physicians. And we have to work together, and this working together will enlighten this gray area of the difficult, it's not the gray area, it's all clear, but the difficult area of diagnosis. So, as a summary, the three sides. One is the medical illnesses which present like psychiatric illnesses, and the psychiatric illnesses which can present like medical illnesses, and the third, the thin round of the coin. Though it's not flat and huge like the other two sides, it's very important, which connects the two sides, because we know it's there. Sometimes they can present simultaneously, or they can present at different stages. So all in all, our lives also have so many sides, aspects. So this is Gall Stadium. There. The toss is, we think that it's the lucky person will win the toss. They can't do anything about it. But we, doctors, physicians, we can do something about things. So if we can think about all the three sides, the probability of winning the toss is high for us. And come to Gaul and enjoy the cricket match, last match of Herangana Herat, and enjoy your life. That is the non-academic side of our life. So thank you very much, and hope you will not miss any of these things, and you will collaborate or liaise with the psychiatric colleagues and do a better job to identify these atypical cases. Thank you very much.